Hello, everyone. Thank you very much for joining us today. We are here to talk about treatment options for fibroids, including the Sonata treatment. My name is Tara Murphy. I'm with Gynesonics, which is the company that is the parent company of the Sonata treatment. And we are fortunate today to have two physicians with us from the University of Kentucky, Dr. Kluck and Dr. Thomas. So you will be hearing from Dr. Kluck and Thomas throughout this presentation. And we're going to talk a lot about different types of information that are of interest to you about fibroids and your treatment options, including Sonata. But this is meant to be an interactive conversation. So if you have any questions, you have any thing that you would like to ask, a story that you would like to share, please put your question or comment in the chat, and we'll be sure to direct that over to our physicians to answer those questions for you. We also have Teresa, who's a Sonata nurse advocate on the webinar with us this evening. And Teresa is an employee of Gynesonics, and she is here to help patients every day to get the information they need about their fibroids and navigate them to physicians in your area, like Dr. Kluck and Dr. Thomas, to have a consultation to see if Sonata is right for you. So thank you both very much for joining us today. It is very nice to have you. So we're going to just start off really top line, just talking about, what are fibroids? So Dr. Kluck, if you could just talk a little bit about what fibroids are.
Yeah, definitely. So fibroids are very common, first and foremost. They're basically growths in the uterus, and they can be in different locations. They can be in the lining of the uterus. Those often cause heavy bleeding or heavier periods. They can be in the wall or the muscle of the uterus, or they can kind of be dangling off the outside of the uterus. And like I said, they're very, very common. They're more common in reproductive age women. So women kind of, starting in their 20s all the way up to menopause. And even up to about 70% of women will have fibroids by the time they reach menopause.
Thank you. And Dr. Thomas, when we are talking about fibroids, can you talk a little bit about what groups of women are they found to be more prevalent? Is there a group? Are there any factors that make you more likely to have fibroids than another woman?
Sure, yeah. So African American women are a little bit more predisposed. That's the highest patient population that we do find our fibroids in, as well as Caucasian women. They tend to run in families. There's not been a genetic or gene that's been found to link these, but a lot of, and Dr. Kluck can also probably attest to this too, a lot of the times when we see our patients in clinic, they report and talk about and tell us their story about how their sister and their mother and grandmother have all gone through the same process. So it tends to run in families.
Yeah, the interesting thing that we hear a lot when we do these patient education events from women is that their mother had fibroids, their grandmother had fibroids. They've seen everyone kind of deal with it, but they thought that it was normal to have fibroids, and they thought that the bleeding that they experienced was normal. So I think it would be great, Dr. Kluck, if you could talk a little bit about what actually is normal from a menstrual cycle perspective, because we do hear so often, oh, my mom and sister bled like this, they've all had hysterectomies, it's just kind of what's going to happen to me. And so a really important part of these webinars is really to make sure that women understand what is normal, so when they're experiencing something that's abnormal, they don't just chalk it up to being something that's related to their family.
Yeah, certainly. I definitely hear that a lot in my clinic too. And one of the interesting things just in general about women with fibroids, they often wait years and years and years before they seek treatment. So like you said, they're sort of silently suffering, or they just think it's, normal for them. But in general, periods shouldn't be occurring more than every 21 days. So if you're having periods that are happening more than, every 3 weeks, that's definitely not normal. If your periods are lasting more than about 7 or 8 days, that's also longer than what we would say is normal. As far as the heaviness of the bleeding, that's really hard to quantify. Obviously, most women aren't sitting there like somehow measuring how much blood they're actually having on their periods, but we certainly say if it's affecting your life, like if you're not able to go to work or go to school, or you're constantly, you're nervous to leave the house because you're worried about soaking through your pad or your tampon, that's certainly more than normal. So those are things that we want you to share with your doctor or your gynecologist for sure. And also pain, that kind of goes hand in hand with the bleeding. Most often people who are having really heavy periods are also having a lot of pain with their periods. So if that's something where, you're taking your ibuprofen or something like that, and you're not getting better, that's something that we want to know about.
Thank you. And, in addition to pain and heavy bleeding, Dr. Thomas, what are some of the other symptoms that you've seen from women who are suffering from fibroids?
Yeah, so Dr. Kluck kind of touched on the one of the branches, which is the bleeding aspect that fibroids bring about. The other secondary kind of group of categories is what we call bulk symptoms. So if fibroids get big enough, they can start to push on the structures that are around the uterus. So the bladder sits above the uterus, the rectum, and the bowel sit below. So if fibroids get large enough, they can start to put pressure on that. And how that presents for patients is either urinary frequency, if there's pressure on the bladder, or constipation, or just a generalized feeling of pelvic pressure or pain. So those are that's a secondary or a different presentation for some of our patients.
Thank you. Dr. Kluck, are there any other symptoms that you see from women that are suffering from fibroids that have come into your office? Or maybe some that aren't quite so common?
Yeah, I mean, I think, oftentimes they're a little more vague, right? So women, if they're pushing on the bladder, they'll say, I just recently, I've noticed I have to pee a lot more frequently, or I've had even some women say they just feel bloated all the time. Their pants are tighter. They notice just like a fullness, a heaviness in the pelvis. Um, Pain with sex is a common symptom of fibroids as well, that not all patients will kind of voluntarily tell you about, but certainly can be caused by fibroids. Um, so those are kind of the ones that I see more frequently, aside from, the heavy periods.
And we have some information on the screen here, but how do women find out if they do have fibroids?
Yeah, and I guess one thing before we move on to that is, like Dr. Cluck mentioned, most of the symptoms and presentations for fibroids, they occur in young fertile women as well. And so I think also if you're having trouble with fertility, that's also another important aspect to remember as well, because fibroids very much can play a role, based off of location, especially if they're in that closer to that inner lining of the uterus, can also play a factor as well. So just wanted to make sure I pointed that out too. And Tara, could you repeat your question? I'm sorry, I blabbered on that one topic.
That's very important. So I'm glad that you brought that up. Thank you. My question is, we've heard a little bit about what fibroids are and what the symptoms can be, and they're going to vary from woman to woman. How would a woman know or be diagnosed with fibroids?
Obviously it starts off with presentation to either primary care physician or OBGYN. They would talk through your symptoms and then more than likely do a physical exam in the office, which generally involves a pelvic exam, both evaluation of the cervix and the vagina, as well as palpation of the cervix and a hand on your abdomen to kind of feel the contour of the uterus. And so that's kind of where we start. And then from there can consider moving on to imaging. That can either be a transvaginal or abdominal ultrasound or an MRI.
Great. Dr. Cluck, anything else you want to add about how a woman may know if she has fibroids or be diagnosed?
No, I mean, I think that pretty much sums it up as far as like our usual. I would say, typically we start with that ultrasound, and we get a lot of information, especially in our ultrasound suite at UK. We're able to do a 3D portion of the ultrasound, and that can sometimes be helpful to figure out, how many fibroids you have, how big are they, where are they located, and kind of go from there. And sometimes, we'll also do some blood work to make sure someone's not anemic or have low red blood cells from the amount of bleeding they're having on their periods, or need iron supplementation ahead of any treatment as well.
That's interesting. We actually have heard a lot of stories from women that you just made me think about that said that they had such heavy bleeding that they ended up in the emergency room, and that's how they actually found out that they had fibroids because they had been, suffering from it for so long, and then they had an instance where it kind of had gone too far, and that's where they started down that path of figuring out that they actually had fibroids. So for those who joined us late, just so you know, this is meant to be an interactive conversation. So if you have questions for Dr. Thomas or Dr. Kluck, please put those in the chat and we will address them throughout this webinar. So the next thing we want to talk about are what are the fibroid treatment options that are out there? And I think an important part of this conversation that we're having today with you all is really to make sure that you understand that, all fibroids are different, all symptoms are different, every woman's treatment plan is going to be different. And a lot of times we hear from women that are talking to us through these patient education events that they didn't know that they had various treatment options for their fibroids. And they kind of had a conversation about one specific treatment, and they didn't realize that there was a variety of treatment options out there. So what we wanted to do was make sure that you all did understand that there are options out there that vary based on every case, is different, and you have to rely on the physician that you're seeing to talk to you about what your best treatment plan would be. But Dr. Kluck and Dr. Thomas, I did want to go into, if you could touch base, just about the common treatments for women with fibroids, and kind of we could talk about it from that least invasive, which is the medical and hormonal therapy, down to a hysterectomy. So if you'd like to talk, one of you would like to talk a little bit about the medical and hormonal therapy first, and then we'll switch off to myomectomy.
Yeah, I can start off talking about the medical hormonal therapy. So the only medication that's really on the market when it comes to actual shrinking of fibroids is a medication called Lupron. Unfortunately, we can't use it for an extended period of time because it can start to have effects on bone health. So really, use is limited to about 3 to 6 months. And then when a patient comes off of that, the fibroids typically tend to grow right back. So a lot of the times, for my own practice, I utilize that to try to shrink fibroids to make a surgical option a little bit more of a viable option. That's how I utilize Lupron. Other medications that kind of fall into this category are geared towards helping with bleeding. Not really, doesn't really help with bulk symptoms, but definitely with bleeding. And these can be hormonal therapies, but what falls into that category, things as basic as birth control pills, progesterone-only therapies, which can include the Depo-Provera shot, Nexplanon, or an IUD. All those therapies are geared towards helping to decrease the amount of bleeding that a patient is having, to try to bring about the proper and acceptable lifestyle for them. And I think the last medication in this category would be tranexamic acid, which is not hormonal whatsoever, but is meant to help to clot blood, to slow down flow during periods as well.
A lot of times we hear from women that when they went on a hormonal therapy, because their symptoms had lessened, they thought that their fibroids stopped growing. Can you talk a little bit about how sometimes that's not the case or is the case for women that are, taking something like a birth control?
So the mechanism of action for a lot of those medications, the way that it kind of brings about that decrease in bleeding is actually by thinning out or decreasing the inside lining, and preventing women from having thickening of that lining, which can then lead to heavier bleeding, that's just precipitated by that fibroid being there. So that's kind of the symptom that you're seeing. And then also when you are on some sort of hormonal suppressive agent, it does decrease the natural production of estrogen, progesterone from your ovaries, which can contribute to decreased stimulation of that fibroid or growth of that fibroid as well, but doesn't really lead to shrinkage of the fibroid.
Thank you. Dr. Kluck, can you talk a little bit about myomectomy and what it is and what the recovery looks like?
Yeah, certainly. So I guess I first just wanted to say that one of the reasons why I get so excited to help patients figure out treatments for fibroids is I feel like we're really lucky nowadays. We have so many good options. I mean, back in the day, if you had fibroids and heavy bleeding, you just would have to have a hysterectomy. And I think we've come a long way from that. And we know from our reading and from kind of big studies, most women don't want a big surgery. They don't want a long recovery, a long downtime. So I think a lot of our patients are coming in sort of looking for other options, and I'm happy that we have things to offer them. And I would hope that if they see a physician who says, nope, you need a hysterectomy, that they kind of keep looking, because there are a lot of good options. So certainly if heavy bleeding is their main symptom, sometimes we do start with some of those medical or hormonal treatments first. And if they're not working, or, things are not as good as they want them to be, then we kind of move on to some of those other options. So myomectomy is a surgery where we actually remove the fibroid itself. And that can be done in different ways. So if the fibroid is only in the lining of the uterus, then we can remove that fibroid through a hysteroscopy or putting a camera in the uterus and then removing that fibroid. And that's a pretty straightforward surgery with an easy recovery, but it's only really applicable to those fibroids that are just in the lining. So most patients have other types of fibroids too that you can't remove that way. So the other way to remove fibroids in the wall or kind of on the outside of the uterus is with actual incisions on the uterus, where we cut the uterus and remove the fibroids that way, and then sew back up the uterus. And that can either be done minimally invasively, so through small incisions, and that's about a 2-week recovery, and patients can usually go home the same day. But if fibroids are really large, or there's a large number of fibroids that need to be removed, then that usually has to be done through what we call an open incision. So usually like a C-section incision, but sometimes an up and down incision on the abdomen. And that is looking at more closer to about like a 4 to 6 week recovery. So.
Thank you. And I have a question that came in. Is a polyp different from a fibroid?
That's a great question. Yeah, they can cause similar symptoms, but they are different in how they form and what they're made out of, and things like that. But polyps are kind of just extra growths of tissue. Like people can form polyps in their nose or their colon and need them removed in other organs too. But when you form them in the uterus, they're in that lining of the uterus. And they often cause bleeding in between periods or heavier periods, or sometimes as well can cause infertility. So when we find a polyp, like on an ultrasound, we do also usually recommend removing that.
Thank you. So we have medical and hormonal therapy. We have a myomectomy, which can be done in a few different ways that lean into a few different periods of recovery times. And then Dr. Thomas, can you talk a little bit about what UAE is?
So UAE, short form for uterine artery embolization. This is actually a procedure that is performed by an interventional radiologist. So myself and Dr. Kluck were gynecologists, but we do partner, and we are very fortunate at University of Kentucky to have a wonderful working relationship with our interventional radiology department. Essentially, going in through blood vessels in the leg, similar to like a cardiac catheterization, and under CT guidance, the interventional radiologists are able to locate and essentially do a roadmap of the blood vessels that are feeding into the uterus, feeding to the specific fibroids. Then they put temporizing gel beads in those arteries to cut off the blood flow to the fibroids. And by cutting off the blood flow, you essentially decrease the life source for those fibroids, and eventually they start to die and then shrink down and go away on their own. That process can take the process itself for the actual surgery is typically same day, good recovery within 1 to 2 weeks. Seeing the actual shrinkage of the fibroid can take up to 3 to 6 months.
Great. Any questions out there from our participants about any of these procedures? Just a reminder, continue to put them in the chat. And then Dr. Kluck, can you talk a little bit about what is a hysterectomy?
So a hysterectomy is, again, that sort of most traditional approach to treating fibroids or heavy bleeding. And what it is it's a surgery that, again, can be performed either laparoscopically so through small incisions or through a bigger incision, depending on the size of the uterus and the size of the fibroids. And it's a surgery where we remove the entire uterus, inclusive of all the fibroids that are with it. Doesn't necessarily mean you have to have your ovaries removed. So if somebody is young and, far from menopause, we often leave the ovaries, but the rest of the uterus is removed with the fibroids. And again, if it's an open surgery, that's, staying in the hospital a couple days and a closer to 6-week recovery. If it's through the smaller incisions, patients can oftentimes go home the same day. And it's more of a 2 to 4 week recovery, I would say.
And can you talk a little bit, you mentioned a little bit about leaving the ovaries. A lot of times we hear from women that they think that if they're having a hysterectomy, they're going to go into menopause right away. And we all often get questions of what's a partial versus a full hysterectomy. Can you talk a little bit about those questions that are very common from women?
Yeah, certainly. We get those questions a lot. So, again, if we leave, if you're young and far from menopause, we would certainly leave your ovaries, and you shouldn't have any change in your natural hormonal fluctuations throughout the month. You obviously won't have periods anymore because your uterus is gone, but you'll still have your normal ovarian function, producing your estrogen and your progesterone and even small amounts of testosterone the ovary produces. So all of that will stay the same. There have been studies that have shown that women who have had hysterectomies do go through menopause maybe 1 to 2 years earlier than average, but it's not something drastic or anything like that. As far as partial versus total, those aren't terms that we use in the medically, but usually that's referring to whether or not the ovaries are taken out or not. There is another type of hysterectomy where we leave the cervix actually in the body. That's called a supracervical hysterectomy. So sometimes that gets kind of confusing with partial and total. But most of the time we usually recommend removing the cervix, especially if we're doing surgery for fibroids, because if you leave the cervix behind, you can actually get growth of fibroids from that tissue that's left behind. So generally speaking, leaving the ovaries in place if women are, not around the age of menopause, and taking out the whole uterus with the cervix.
Okay. So I have a question that's come in the chat, which is how does fibroid size and number affect outcomes for different removal or reduction options?
Yeah, it's a great question. So I know in my own clinical algorithm and pathway to decide and what I'm going to offer, the number of fibroids and the location come into play. So let's say a patient has multiple, we're talking greater than 5 fibroids that especially are at the inner layers of the uterus or smack dab in the middle of the muscle. In those situations, I'd lean more towards offering an open myomectomy if that's how they wanted it removed. And we're going to talk a little bit later about kind of how the landscape has changed a little bit, because now with the ability of Sonata and fibroid ablation, we can altogether get rid of even having that open option. Now, if you have large fibroids, but typically between 3 to 5, for those types of patients, I feel pretty comfortable offering a laparoscopic approach. The reason for that is because if we don't have to make too many incisions, it's much easier to close those incisions that we have to make on the uterus in order to remove the fibroid. And then from there, we're able to take them out through a mini C-section scar, which is typically about 4 centimeters, still able to keep everything minimally invasive for patients.
Thank you. So you mentioned Sonata. So we're going to talk a little bit about what Sonata is. So Dr. Kluck, do you want to talk a little bit about what Sonata is? And then Dr. Thomas, you could talk a bit about what your experience has been with Sonata.
Yeah, certainly. So Sonata is a minimally invasive energy-based treatment for fibroids, and it actually uses that energy to shrink the fibroids over time and then decrease patients' symptoms from their fibroids. It's totally within the uterus, so there's no incisions, and it's a pretty easy recovery from the grand scheme of things as far as other procedures that we offer for fibroids.
And Dr. Thomas, do you want to talk a little bit about what it looks like for a patient to, come in to have Sonata? What does that experience look like for a woman?
So it's a similar approach to what Dr. Kluck had mentioned earlier with the hysteroscopy. It's a same day surgery for patients. We do have the ability to not have to put patients under general anesthesia, so we can use more like a twilight sedation, if you will, similar to what we use for colonoscopies and things like that. Um, just because of the minimally invasive approach um, to this procedure. Everything is done through the vagina, like Dr. Cluck had mentioned, incisionless, all within the uterine cavity and the muscle wall of the uterus. So very good recovery for the patients, and heard from my patients only good things about their recovery.
Great. And I have a question that's come in. What size range of fibroids are too big for Sonata to be considered effective? It's a great question.
Yeah, so the upper limit, and our Sonata team that's on can correct me, but 10 centimeters is kind of the max level of what is considered too big. Part of what factors into that is the amount of energy that's taken to try to ablate or bring about the death of those fibroid cells. Um, so that's kind of that upper limit. There's also a lower limit as well when fibroids can actually be too small to be used. Typically, that's about anything less than 2 centimeters. So usually between that 2 to 10 centimeter range is fair game for the Sonata. That being said, though, let's say you have a larger fibroid, it's also very reasonable for us to consider doing these things as stage procedures, if you will. So doing an ablation, waiting 3 to 6 months, doing a repeat ultrasound to see the level of shrinkage that you've had on your fibroid, and if you're still having symptoms, or want us to go after it again, that it's reasonable to do a second procedure to try to ablate and bring about a smaller size to that fibroid.
And can you talk about the number of fibroids that you could treat with Sonata? Can you treat only one fibroid during a procedure, or can you treat multiple fibroids at the same time?
Yeah, oh, go ahead.
Oh, go ahead, Sarah. No, no.
Oh, I was going to say, yeah, no, that's one of the nice things about this specific procedure is that we can treat multiple fibroids in one, setting at the same time. So essentially, the handpiece that we use has an ultrasound tip at the end of it. So it gets placed through the cervix into the uterus, and that's how we identify each of the fibroids that we want to treat. And once we treat one, then we move on, move the handpiece around to find the next fibroid and treat and ablate, all the fibroids that we see that way. Again, correct me if I'm wrong, but I believe we can treat up to 10 fibroids probably in one setting. But certainly it depends on how big each of them are and where they're located.
Thank you. Any other questions from the participants? Please feel free to put it in the chat. I'm going to put on here, as we always have to, is just our intended use statement. So this is a required slide that we have to put up for our webinar. So you can find this information on our website if you would like to get additional information or read in more detail. And then let's talk a little bit about how you can find a physician in your area. So, as we had mentioned before, it's really important to find physicians that are willing to talk to you about your specific case and all of your treatment options based on the size and type of fibroids that you have and where they're located. So it's very important to find physicians like Dr. Kluck and Dr. Thomas in your area, which you can do, and you can find them specifically as well on our website on sonatatreatment.com. We have a physician locator there where you'll be able to find both of their names and contact information. And Teresa, who is our nurse advocate who's on, is also available through our website, and she will be able to direct you to their office as well. Any other questions for anyone in the chat?
And
Okay.
Tara, while we're on this slide, for our participants, I definitely wanted to encourage, like what Dr. Cluck had said earlier, we want our goal as gynecologists and as GYN surgeons always to make sure that we are tailoring our treatment to what you as the patient desire. And so, what I mean by that is if what a physician is telling you doesn't jive with what works for your lifestyle, we're always going to be here to highly recommend that you look for your other options, because that's one of, I think, the biggest points that we wanted to point out today, was to make sure that you as women understand that there are so many different options out there, especially when it comes to fibroid management. And you got to pick the right one that works for you. And we feel very blessed and lucky at University of Kentucky to be able to have all of these things at our fingertips, or colleagues that we can refer you to in order to kind of maintain the goals that you are hoping for.
Thank you. Dr. Kluck, anything else you would like to say?
Yeah, no, that was exactly, summarizing kind of how I feel as well. I mean, one thing we didn't really touch on was like side effects, or, things to expect after you have the procedure. And I'm sure patients may, have questions about that. I'm sure it's on the website, but in general, side effects are really mild and usually pretty short-lived. So, we can touch a little bit about that. And then if people have questions, dive into it more. But spotting, cramping is definitely something to expect in the beginning, and a little bit of pelvic pain. Most patients are back to normal within 2 days. Up to a week, I would say, is still normal, but most patients are back to their usual activities a couple days later. And all that you really need afterwards, if you have the Sonata treatment, is over the counter like ibuprofen, or Tylenol to help with sort of that cramping pain. And the other side effect that patients have talked about is some abnormal discharge. And that happens because those fibroids that we treat and ablate, as the body's reabsorbing them, you can kind of see some of that tissue come out in the form of some abnormal discharge for even up to a few months, patients report. So as long as people know and kind of expect that, then it's not a surprise, afterwards. So just wanted to make sure people understand, what happens after the procedure as well.
Yes, that's very important. So thank you for touching on that. Does anyone have any questions on the recovery time, Sonata, or any of the other treatment options? This is prime time. You have Dr. Kluck and Dr. Thomas right here to answer all of the questions that you have. So please, feel free to put them in the chat, and we will be sure that they answer your questions for you. I'm also putting in the chat right now the website so that you can find more information and to be connected to our physicians. There's a question that just came in. How likely and what is the timeline for new fibroid growth after Sonata?
So regardless of whether it's Sonata or a classic myomectomy, typically the chance of growth that I quote for patients is 50% chance within 5 years of any surgical procedure. And Sarah, if you use a different number, please let me know. But that's typically what I counsel all my patients on, whether we are doing a myomectomy, a uterine fibroid embolization, or uterine fibroid ablation. All of those minimally invasive procedures, they all have that chance of regrowth of fibroids within 5 years.
Yeah, I think that's a good question. The hard thing about fibroids is that for every patient, different things can happen. So even if you don't do anything to your fibroids, in some patients, they can get smaller. In some patients, they stay the same. And other patients, they continue to grow. So new fibroids, it's hard to kind of predict whether you'll form new ones. I usually tell my patients if we do a myomectomy, so if we cut out the fibroids, there's about a 25% chance that they may need another procedure within 5 years. So, and then I just don't think we have enough kind of long-term studies after the Sonata to know for sure, although up to the 3-year mark, I think it's close to about 9 out of 10 patients don't need any other intervention. So their symptoms are pretty well controlled. It's not to say that new fibroids haven't started to come back, but overall their symptoms are at a place where they're happy with them. So.
Thank you. Any other questions? Okay. Dr. Kluck, Dr. Thomas, thank you very much for your time. Um, as you all know, you could find them on sonatatreatment.com. They are at the University of Kentucky, so you will be able to find them on the locator, or if you connect with Teresa, our nurse advocate, whose information is on our website, she will be able to connect you with their office to schedule a consultation and see which procedure is best for you. So thank you all very much for sharing your insights, your information. We greatly appreciate you helping to educate women about fibroids and all of their treatment options, including Sonata.
Thank you so much for having us, and thank you so much for our attendees for logging in tonight. We appreciate it.
Absolutely.
Yeah, thank you so much for having us.
Thank you. Have a good evening, everyone.